Hypertension is defined as a persistent elevation in arterial blood pressure associated with a progressive increase in cardiovascular morbidity and mortality. Rather than being a single disease, it represents a chronic hemodynamic disorder that accelerates atherosclerosis and promotes end-organ damage involving the heart, brain, kidneys, and vasculature. The goal of therapy is therefore not only blood pressure reduction, but global cardiovascular risk reduction. According to the American College of Cardiology and American Heart Association guideline, hypertension is categorized to guide treatment intensity rather than just diagnosis. Normal and elevated blood pressure require lifestyle modification only. Stage 1 hypertension requires risk-based decision-making using ASCVD risk assessment. Stage 2 hypertension represents established disease and requires pharmacologic therapy. The key concept: we treat risk, not just the number. Hypertension remains the most prevalent modifiable cardiovascular risk factor worldwide. Even small reductions in systolic pressure significantly reduce stroke, myocardial infarction, heart failure, and chronic kidney disease. Therefore, treatment produces population-level mortality benefit greater than many acute cardiovascular interventions. Blood pressure is determined by cardiac output multiplied by systemic vascular resistance. For major physiologic regulators interact continuously. Sympathetic nervous system controls vascular tone and heart rate. Renin-angiotensin-aldosterone system regulates vasoconstriction and sodium retention. Kidney sodium handling determines long-term volume status. Endothelium releases vasodilators such as nitric oxide. Chronic hypertension develops when these systems reset to a higher pressure equilibrium. Hypertension is not caused by a single abnormality. It results from multiple reinforcing mechanisms. Persistent sympathetic activation increases vascular tone. RAAS activation promotes vasoconstriction and aldosterone secretion. Sodium retention expands intravascular volume. Endothelial dysfunction reduces vasodilation. Arterial remodeling causes stiffness. Over time, systemic vascular resistance becomes permanently elevated. This is why long-standing hypertension becomes progressively harder to control. Primary hypertension accounts for about 90 to 95% of patients and results from genetic susceptibility interacting with environmental factors such as diet, obesity, and aging. Secondary hypertension should be suspected in resistant hypertension, abrupt onset, or early onset disease. Common causes include chronic kidney disease, primary aldosteronism, renal artery stenosis, obstructive sleep apnea, endocrine disorders, and medication-induced hypertension. Identifying secondary causes is critical because treatment may be curative rather than lifelong. Initial evaluation has 3 objectives. 1. Confirm the diagnosis with accurate measurements. 2. Estimate cardiovascular risk using ASCVD scoring. 3. Detect target organ damage. The presence of organ damage automatically increases treatment urgency regardless of the absolute blood pressure number. Hypertension damages organs through chronic pressure and endothelial injury. Heart left ventricular hypertrophy and heart failure. Brain stroke and TIA. Kidney albuminuria and reduced eGFR. Vasculature peripheral arterial disease and aortic disease. These complications define hypertension severity more than the BP reading itself. Guideline-directed therapy follows risk-based thresholds. Stage 1 hypertension. Treat only if ASCVD risk greater than or equal to 10%. Stage 2 hypertension. Treat all patients. This approach prevents overtreatment of low-risk individuals and undertreatment of high-risk patients. For most adults, the recommended target is less than 130/80 mm of mercury. Patients with diabetes, CKD, or established ASCVD benefit the most from intensive control. However, therapy must be individualized in frail or elderly patients to avoid adverse effects such as orthostatic hypotension. According to current recommendations from the American College of Cardiology and American Heart Association, initial pharmacologic treatment of uncomplicated hypertension should begin with one of four first-line classes: thiazide or thiazide-like diuretics, ACE inhibitors, angiotensin receptor blockers, or dihydropyridine calcium channel blockers. These agents have the strongest evidence for reducing stroke, myocardial infarction, and heart failure, and therefore are preferred over other antihypertensives regardless of their ability to lower blood pressure numerically. Thiazide diuretics reduce blood pressure initially through natriuresis and volume reduction, and chronically by decreasing peripheral vascular resistance. They are particularly effective in salt-sensitive hypertension and in patients of African ancestry. Chlorthalidone is generally preferred due to longer duration and stronger outcome data. ACE inhibitors block conversion of angiotensin I to angiotensin II and reduce aldosterone secretion while increasing bradykinin. They provide both blood pressure lowering and organ protection, particularly slowing progression of proteinuric kidney disease. Cough and hyperkalemia are the most clinically relevant adverse effects. Angiotensin receptor blockers selectively inhibit the AT1 receptor, preventing vasoconstriction and aldosterone release without increasing bradykinin. They are preferred alternatives when ACE inhibitor cough occurs and have similar cardiovascular and renal outcome benefits. Dihydropyridine agents cause arterial vasodilation and primarily reduce systemic vascular resistance. Non-dihydropyridines additionally reduce heart rate and contractility but are less commonly used solely for hypertension. Dihydropyridines are generally preferred due to stronger BP lowering and tolerability. Treatment escalation follows a structured approach. Stage 1: Start 1 agent. Stage 2: Start 2 complementary agents. Reassess in 1 month and intensify therapy if uncontrolled. Early combination therapy improves adherence and accelerates blood pressure control. Preferred combinations therapy include ACE inhibitor or ARB plus thiazide, ACE inhibitor or ARB plus calcium channel blocker. ACE inhibitor and ARB together should be avoided due to increased renal and potassium complications without outcome benefit. Resistant hypertension is defined as uncontrolled blood pressure despite 3 agents including a diuretic. Management includes confirming adherence, excluding secondary causes, and adding a mineralocorticoid receptor antagonist such as spironolactone, which is the most evidence-supported fourth-line agent. Hypertensive urgency is severe elevation without organ damage and is treated with gradual oral reduction. Hypertensive emergency involves acute organ injury and requires immediate intravenous therapy and ICU monitoring. The key distinction is damage, not the number. Patients should be followed monthly until controlled. Laboratory monitoring includes electrolytes with diuretics, creatinine with RAAS blockers, potassium for safety. Home blood pressure monitoring significantly improves control and adherence. Hypertension is a cardiovascular risk disease rather than simply a pressure abnormality. Target blood pressure is below 130/80 for most patients. First-line therapy includes thiazide diuretics, ACE inhibitors, ARBs, and calcium channel blockers. Combination therapy is frequently required, and lifestyle modification remains foundational.